we are going to dissect on the two trials, Nefigard as well as the PROTECT trial. So to introduce first, IgA nephropathy is the most common glomerulonephritis worldwide with a 20 to 30% progress to ESRD in the first 10 years. It was described by Jean Berger in 1968, and it has got variable incidence around the world and has got varied clinical presentation. As Iqbal sir mentioned, that the pathogenesis has been ever evolving, and each time we come across newer set of hypothesis, which here is a multi-hit hypothesis where initially the innate immunity as well as the mucosal immunity, where the inherited defect of the IgA1 glycosylation, that is along with dysregulated response to the mucosal antigens, lead to the elevated levels of circulatory galactose deficient IgA1, against which the adaptive immunity sets a reaction for which production of anti-glycan autoantibodies take place. With HIT1 and HIT2 in combination, we go to the third part of the formation of the immune complexes which are circulating. And that is HIT3, which lands up in our kidneys at the level of the mesangial deposition of these immune complexes, leading to eventually kidney injury, which is presented as hematuria, proteinuria, and decline in GFR. And with this knowledge of molecules acting at different levels, whether it is at the mucosal level, the drugs and the treatments have also evolved accordingly. You have got budesonide at that level. You have got inhibitors of BAFF and APRIL in the form of etacept, and even the alternate complement pathway involved at the level of the tissues are also now target sources for development of treatment. These are some of the histopathological scenes in IgA nephropathy, where we understand that as a MESC scoring, where we got mesangial hypercellulose, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, eventually leading to fibro, and also the more pathological IgA in the terms of cellular and fibrocellular crescents. In spite of having all these targets, we are still in the KDIGO guidelines at level of supportive therapy in IgA nephropathy, whereby we deal with blood pressure management targets of BP around 120 millimeters of mercury, with first choice antihypertensive being the ACE inhibitors and the ARBs, which help us in reduction of proteinuria to maintain less than 0.5 gram per day. At the same time, you can also add in some beta blockers or aldosterone antagonists to the regimen for antihypertensive management. In the dietary advice, we generally tell the patients to restrict the sodium to less than 2 grams and control the protein intake and control of fluids. In light smoking, normalize the body weight and encourage sports and activities and yoga and medications. Additional measures, we ask them to avoid NSAIDs, avoid prolonged severe hyperkalemia or any other sort of usage of drugs, and also addition of newer drugs, which has come SGLT inhibitor, which is currently evidenced in DAPA-CKD trial. So we are at this point in the treatment, though there were landmark trials with the use of immunosuppression in IgA nephropathy, that is mainly steroids, with the landmark first trial coming at 1999 by Pozzi et al., where BP control plus diuretics versus IV steroid was used, and there was shown a reduction in proteinuria. The same also was replicated by Mano et al., where they used ACE inhibitors plus oral prednisolone as one group versus ACE inhibitors, where the prolonged 8-year study could show the positive reduction in albuminuria. LV et al. Meta-analysis of the steroid use in 2012 proved to be showing that there is effect, but there is also side effects of steroids, not that severe, but at least 50% of the patient had side effects of steroids, which then we went on to see in the STOP IgA trial, where we had immunosuppression versus RAS inhibition and testing trial, where again it was shown that steroids were having respective side effects, and it put an halt to the use of immunosuppression as a part of treatment protocol. Just looking into in brief about the trial which we mentioned previously, the STOP IgA trial, where it was a 36 months supportive care versus immunosuppression, and in patients with normal GFR, it was IV steroids for 6 months, and in patients which had between 30 to 59 GFR, they had used cyclophosphamide for 3 months and then switched on to azathioprine and oral steroids to find out that there is definitive reduction in proteinuria, but that doesn't translate to the GFR reduction or any improvement in GFR at the end of this is with severe infections, glucose intolerance, weight gain, and other side effects of steroids. Also, the LV et al. Paper on testing trial, where they used the dose of 0.6 to 0.8 milligrams per kg per day of methylprednisolone versus placebo, which had to be stopped interimly because of the serious adverse events, 28% versus 4. And later on, there was a continuation of the testing trial with the low dose methylprednisolone of 0.4 milligram per kg per day to show some positive effects, definitely in terms of the reduction in albuminuria, but even the side effect profile was less because of additional of PCP prophylaxis and antibiotic support. So with this standpoint, we came to a newer drug that was dapagliflozin through the DAPA-CKD study. Told us that in a cohort of IgA nephropathy they found that actually there is a reduction of 26% change in the urine albumin creatinine ratio, and also the reduction of GFR in terms of dapagliflozin was minus 3.5 versus minus 4.7. That is, a decline was more in the patients who were in the placebo group. But in spite of all this happening, there is a need for newer drugs. That is because standard of care continues to be supportive therapy. There is no evidence for traditional immunosuppressive agents like cyclophosphamide, azathioprine, MMF, or rituximab. MMF still has come up in a little book because of the Chinese studies which are recently published. Safety and efficacy of systemic steroids have been challenged as by testing and stop IgN trial. And there is definite clear unmet need for safe and effective disease-modifying therapies in IgA nephropathy. The spectrum is wide open. We are looking at as in the pathogenesis, mucosal immune system effect by using Nefigard tablet, that is a targeted release budesonide, which will be looking very recently in the next few slides. The effect on B cells by drugs like etacept, sidapim, prelilab, belimumab, Bion 1301, the studies of which are underway. Complement inhibitors like ravulizumab, avacopan, and the recent one of the narsoplimab is underway, as well as now looking into non-immune modulators like specifically sparsentan and atorsentan, which we are looking into today's study, as well as the glyphosins, which we already saw in the DAPA-CKD study. So because of the upcoming drugs and the need for new drugs, we are looking into the first one, that is the Nefigard trial. The Nefigard trial is a result from a part A of a multi-center, double-blind, randomized controlled trial, which evaluated the targeted release formulation of budesonide for the treatment of primary IgA nephropathy. It was by Jonathan Barrett et al. And it was published in the Kidney International 2022 October 19 edition. So what is targeted release budesonide? Budesonide is a second generation synthetic non-halogenated corticosteroid. So it has acting locally with minimal systemic absorption. The molecule is non-fluorinated as well as non-symmetric at 16 alpha and 17 alpha. Because of these two characteristics, it is having a good topical anti-inflammatory activity. And budesonide undergoes very high first-pass elimination by liver. So the systemic levels are minimal after oral administration. The mechanism of budesonide action is basically what we are targeting here is the Peyer's patch, where from all this source of IgA1 and the defected mucosal antigen immunity response to it antibodies are formed. So we are trying to get this drug act at this point by using a pH technique, whereby which the drug will get opened up at that particular pH of 6.4. It reduces the release of pro-inflammatory cytokines from epithelial cells, lymphocytes, and macrophages, thereby reduction in IL-6, IL-8, interferon alpha and beta. It represses the NFK beta dependent transcription and the mitogen activated protein kinase pathway. So similarly regulating the inflammatory as well as the immune mediated reactions. So this is basic of the action of budesonide in this particular Peyer's patch. The study design, it was an international multi-center phase 3 trial. It was basically a follow-up of an Igkn trial, which was a phase 2 trial. So it is 112 sites in 20 countries. It was 15 to 35-day screening period. Part A, the 9-month treatment period with 16 milligrams of OD dose of oral budesonide with a 3-month follow-up with a further 12-month observational period for eGFR. So the part B is basically after the part 1, whereby there is a tapering of 2 weeks of the drug with an observational period of 1 year. So we are with the results at the moment of part A has been published. Part B is expected any point of time in the end of by this year. In the inclusion criteria, they have taken UPCR of proteinuria more than 1 gram per 24 hours, EGFR, which is more than 35 but less than 90, maximum tolerated or allowed ACE inhibitor or ARB for 3 months prior to randomization, controlled diabetic type 1 and type 2 with an HbA1c of less than 8, and IgA nephropathy on biopsy in the last 10 years were included in this study. In the exclusion criteria, secondary forms of IgA nephropathy, non-IgA nephropathy glomerulonephritis, which included HSP, inadequate blood pressure control where BP is still on the higher side, more than 140/90, kidney transplant patients, treatment with systemic glucocorticoids or other immunosuppressants in any of the 12 months prior to enrollment, and the high-risk patients like peptic ulcer disease, moderate osteoporosis, poorly controlled diabetes, and chronic infections were excluded from this study. The outcome was looked at, primary outcome was reduction in proteinuria, which should be measured by 24-hour collection at 9 months. And secondary outcomes were EGFR at 9 months, urine albumin creatinine ratio at 9 months, and EGFR at 12 months. This is in relation to the part A of the study, which has been published. So out of the 657 screened, they could get N is equal to 153 in Nefigard group and N is equal to 153 the placebo group, to end up with a total number of 97 and 102 in the respective groups. The demographics and baseline characteristics of these patients have summarized into a slide. 67.8% male were present, 85.9% were white in this population. So majority were in the Caucasian population. 54.2% were of the age around 45 years of old. Medium UPCR was approximately 1.26 gram per gram. 60% with baseline proteinuria was having more than 2 grams of proteinuria, and the baseline median EGFR was around 55 ml per minute per 1.73 meters square. 65% of these patients had microhematuria by dipstick at baseline, and higher percentage of patients in Nefigard group had diabetes. But in the inclusion criteria, we had mentioned with HbA1c less than 8 as well as well controlled. The end of 9 months, it was found that 27% of the patients had a reduction in UPCR, 31% in the reduction of UACR, and at 12 months, it improved to 48% in the Nefigard group as well as 54% reduction in proteinuria. The safety profile of these patients, there was discontinuation because of treatment emergent adverse events, only 9.3% in the Nefigard group versus 1% in the placebo, mainly because of hypertension, peripheral edema, muscle spasms, and acne. Nothing very serious or very severe was found in these. 2.5% showed severe reaction, but its severity was unclear in the study. And 4 patients had such a reaction in Nefigard group and 1 patient in the placebo group. Infective events were very similar between the two groups, 39.2 versus 41% in the placebo group. So basically, there was no severe infections causing hospitalization, or there were no deaths in this study. So efficacy point of view, it was found that at 9 months with optimal RAS blockade, proteinuria, there was a 31% reduction in Nefigard group compared with 5% in the placebo group. Proteinuria improved in the Nefigard patients at 12 months as well. 12 months means there was a 3-month extension phase where the patient was not on any treatment drug. So basically, he was on only optimized care. In spite of that, there was proteinuria improvement as we saw in the previous slide as well. Baseline glycosylated hemoglobin had no impact basically on the primary endpoint. Limitations of this study basically included that, as we saw, that the percentage of whites were very high, this mainly primarily Caucasians, almost 84%. So the race is nothing much to do with the thing of IgA nephropathy, but we find that Asians have sometimes more aggressive disease compared to the Caucasians. Specifically, even in the IgA prediction tool, which has been prepared, there is discrepancy in our population compared to what is mentioned in their white population. Contemporary biopsies were not required. This prevented an association being made between histological features and their response to treatment. So we don't have that set up in this particular group. Comparison with the placebo, basically it was done with a placebo, not any other particular drug as such. Location of action and mechanism of Nefigard is still speculative. So we require further biomarkers and studies relating the same to be made sure that this action continues as discussed. So if you have to summarize the whole study of Nefigard in a particular single slide, this visual abstract. It was a paper by Barrett et al. 2022. Results from the part A of the multi-center double-blind randomized placebo-controlled trial which evaluated the target release of formulation of budesonide for the treatment of primary IgA nephropathy. 201 patients, 16 milligram OD dose versus placebo n is equal to 9 months was the treatment period, 3 months was the follow-up period where there was no drug given to the patient. Optimized RAS blockade was given to all. Medium UPCR was 1.26 gram per gram. Medium proteinuria was 2.26 grams in 24 hours. And 58% of the population had more than 2 gram proteinuria, which is a very significant inclusion. And median EGFR was around 55 in this study. At the end of 9 months, there was 27% reduction, as well as 48% reduction at 12 months in UPCR, as well as the eGFR at 9 months. The treatment benefit was about 3.87 ml per minute per 1.73. And the slope of improvement as well was approximately around 3.37 ml per minute. Safety-wise, we had seen that there was equal adverse events in both groups, so there was no serious infections or requiring hospitalization. So in conclusion, the study mentioned that 9 months of treatment with Nefigard, in addition to the optimized and stable RAS blockade, was very well tolerated and resulted in clinically important improvements in urine, UPCR, UACR, and eGFR compared with the optimized supportive care alone. And we wait for the part B to come, where we'll understand the effect on eGFR, whether it could reach the further standpoint. So with this, we come to the next one, the second trial, which is the PROTECT trial. The PROTECT trial is a randomized, multi-center, double-blind, parallel group active control trial that examines sparsentan, the first-in-class compound, which is a combination of angiotensin type 1 receptor blocker and endothelial type A inhibitor in comparison to irbesartan, an angiotensin receptor blocker for treatment of IgA nephropathy. The objectives was to determine the effect on proteinuria and preservation of renal function as compared to an ARB when assessing the safety as well as monitoring the endpoints. When you look at sparsentan, it's a dual endothelial angiotensin 2 receptor blocker, which is also nowadays known as DERA. Basically, endothelin 1 has an ETA receptor blocker. Basically, ETA functions by causing vasoconstriction and endothelial damage, inflammation and fibrosis, podocyte damage and glomerular permeability increase, and albuminuria. And this in combination with angiotensin 2, which causes vascular dysfunction, glomerular dysfunction, and tubulointerstitial injury, further worsens the thing. So this blocker helps in reversing these actions of the respective receptors and molecule. Sparsentan is also in other trials with DUET trial in FSGS, duplex trial, phase 3 is going on in FSGS. We are discussing PROTECT. It's also in Spartan trial for IgA nephropathy and also oncovasculitis phase 2 trial going on with this particular molecule. So when you look at PROTECT trial, basically it's an international multi-center, 134 clinical practice sites at 18 countries. It's a double-blinded randomized trial. Study duration is around 270 weeks, of which 114 weeks is double-blind period and 156 weeks is an open-label extension of the study. The interim analysis was presented at 36 weeks on the primary efficacy endpoint of change in proteinuria was looked into. The drug use was sparsentan to begin with at a dose of 200 milligrams to end up with 400 milligrams once daily versus irbesartan, which started at 150 milligrams and then proceeded to 300 milligrams once daily, was the active control. So it is drug versus drug. When you look at the inclusion criteria, you got that age is more than 18 years, biopsy proven IgA nephropathy in any time in the past. So there was not a specified time period. 24-hour urine protein excretion more than 1 gram, eGFR above 30 ml per minute, stable dose of ACE or ARB for at least 12 weeks before screening. So before screening, where they are on the maximum optimized dose in the 12 weeks, maximum tolerated dose and at least 1/2 of maximum labeled dose, and the blood pressure maintained below 150/100 millimeters of mercury. The PROTECT study exclusion criteria, similar like the other, secondary IgA or IgA vasculitis, cellular crescents, if present, and less than 6 months before screening. Cause for CKD in addition to IgA nephropathy. Systemic immunosuppression for more than 2 weeks or less than 3 months before screening, and significant cerebrovascular, cardiovascular, or hepatic-related conditions. So 671 patients assessed for eligibility, of which 265 got excluded, 406 randomized and enrolled, of which 2 again had some study drug taken. So divided into 202 irbesartan and 202 receiving sparsentan, of which 105 treatment ongoing, 58 completing, and 114 treatment on sparsentan with 65 completed treatment. So when you look at the basic characteristic, patient characteristic, this slide is basically for patient characteristic. On the right side, you'll notice that the patient number was 404. Median age was around 46. The stage of CKD was 35% were in 3A. Baseline median 24 hours was protein leakage was 1.8 gram per day. Percentage of maximum ACRB people who got stabilized was 63.4% with a mean BP of 129/82 millimeters of mercury. More importantly, in this slide, what is to be projected is the population variety. Basically, Europeans 53%, but we had North Americans 20%, but mostly we also had Asia Pacific representing 27% of this population. And in Asia versus non-Asian regions, there are a higher percentage of females in this. The BPs were lower, and the lower percentage baseline hypertension and related treatment were going on for these patients. So this had a little bit of a better representation of the general public population as compared to our previous Nefigard study. So the outcomes, primary endpoint was change in baseline urine protein creatinine ratio measured by 24-hour urine sample at week 36. And secondary endpoints, basically looking at the urine albumin creatinine ratio, complete versus partial remission, proteinuria remission at least once during this double-blind period, and proportion of patients who are reaching a confirmed 40% reduction in eGFR from baseline. So these were the outcomes, primary and secondary. As we see in this particular graph, there is a definitive reduction of 49.8% in urine albumin excretion in the sparsentan group at 36 weeks compared to 15.1% in the irbesartan group. And similarly, in the patients who achieved complete proteinuria remission, that was less than 0.3 gram, it was 21% in the sparsentan group compared to 8% in the irbesartan group, which was also in partial remission, reflected in terms of 70% in patients who had sparsentan compared to patients who were 44% on irbesartan. So there was definite benefit with the use of sparsentan versus irbesartan. In the side effect profile, side effects known with endothelin receptor antagonists like fluid overload, hypotension, elevation of transaminase were mostly non-severe and similar to the control group as well. So both groups had very high incidence of adverse events, smaller adverse events, 88% in sparsentan group and 78% in irbesartan group. There were no fluid overload related SAEs such as heart failure, and even the use of diuretics were similar in both the groups. The participants were very carefully selected to avoid such side effects. The limitations of the study was that there was exclusion of patients who were on fluoresceins in the initial phase. because the time at which the DAPA CKD and the EMPA kidney results had come, they already had gone ahead with planning and initiation of the PROTECT trial. And timing of kidney biopsy was not a recruitment criteria here, so nor was the degree of histopathological severity. So there was no comparison with histopathological outcomes in terms of treatment. Conclusion of this particular study was that sparsentan ET1 AT1 receptor blocker had, when compared to irbesartan ARB blocker, favorable effects on proteinuria reduction 49.8% versus 15.1% among patients with IgA nephropathy with proteinuria more than 1 gram and EGFR more than 30 ml per minute. There were comparable side effect profile between the two groups, and the end-stage kidney disease, a 40% decline of GFR is still underway. The study is further reports will come in the near end of the year, where as of we are uncertain of the benefits on that. So when you summarize the PROTECT trial, basically it is 134 sites in 18 countries. It was presented in the Lancet in 2023, April 1st by Harp Singh HG et al., where 18 countries participated, 404 were randomized, and basically it's a biopsy-proven IgA nephropathy, proteinuria of more than 1 gram, despite maximum RAS for more than 12 weeks. Before randomization into sparsentan and irbesartan, the RAS1 blockers were stopped. Initially, they were given 200 milligrams for 2 weeks and 150 irbesartan for 2 weeks, which was then extended further for 400 milligrams per week and 300 milligrams in the following weeks after the initial interim. And the interim analysis was at week 36, which was predetermined, and the primary outcome showed a decrease of 14.8% of proteinuria. Adverse events were almost similar. Edema leg was present in both, almost little more in the sparsentan group as expected. Blood pressure fall was more in the BP group. AKI incidence was almost similar, 4% versus 1%. And they concluded by saying that once daily treatment with sparsentan produced meaningful reduction in proteinuria compared with irbesartan in adults with IgA nephropathy, safety of sparsentan was similar to irbesartan.